Good afternoon, all. I want to formally welcome us to the June meeting of our group, Pediatricians in Private Practice Group. And today is going to be exciting. Exciting in the sense that we're presenting a surgical case. And this is going to be the first surgical case in our series. And we have Dr. Njokanma from Lifeline Children's Hospital, presenting with a young, dynamic pediatric surgeon, Dr. Felix Alakal. I hope I got that right. So, and in our usual tradition, I'd like to hand over to the chair to say a few words before we start. Over to you, sir.
Okay, thank you, Sandy, for the brief introduction. And I have pleasure in welcoming everybody, our members, participants, and our guests. In particular, I wish to acknowledge in our midst the presence of the president of the Pediatric Association of Nigeria. That's our parent body, Professor Femi Ogunride. And also acknowledge Professor Adenike Grange, who is just joining us now, and everyone who is here. You know, today, June this year, makes it 1 year since our organization started. It was precisely on the 5th of June, 2021, that I sent out the first message on a few platforms, asking if people would like the idea and if they would like to join, with a little bit of apprehension, not knowing really how it would go. And it took off from there, like every idea whose time has come. And it has not looked back since that time. Today, we have 101 participants in the group, and the group is growing. And I just want to briefly acknowledge everyone, all of us who has contributed to the success of this group. Starting with the initial person, the first convert or disciple, I may say, Dr. Iletu, you know, who is the chief coordinator. He is the first person I spoke to about it. And I'm so happy that he has taken up the mantle and is, you know, proving that he's a very, very worthy partner in this process. And also initial people that joined us, Dr. Akinwumi, Dr. Fajulu, Dr. Odudu, and other members of the ESCO now, Maria Mutayola, Dr. Orode Duarte, Sivaline Nwizu, Dr. Uche Ononiwu, and Dr. Onifade, who is leading continued professional development, non-clinical diaspora group. You know, when this started, I got tremendous support from elders of the association, especially Professor Grange, who is here with us, Dr. Ajeni Fuja. Both of them have made sure that they attended all our meetings so far, Dr. Ame Idoko, and others who are now trustees, including Dr. Esangbedo, Professor Ipeziako, Dr. Agbato, and many past presidents of the Pediatric Association of Nigeria. This gave us a lot of confidence at the beginning. And then the support that we had from the presidents of the Pediatric Association of Nigeria, starting with the immediate past president, Professor Alakal, and now Professor Femi Ogunride, who indeed has shown it by being present with us at this meeting today. So I want to thank the Pediatric Association and the presidents and all our elders for the advice and the suggestions which they have put forward. And not the least, all the participants in the group for keeping the group in a very professional way, making it interesting. Every member of the group will attest that value is being added on a daily basis, value that is improving competence in the practice of pediatrics, and which will ultimately show in the way the children in our care are looked after. I also want to commend the discipline of the group, that our meeting starts on the dot of 3 o'clock. I think it's one of the few professional groups which have been that actually starts their meeting on time. And I would encourage that we keep this and other little things that we are doing well. We keep on doing them, because these are the things that, you know, stands us apart from other groups. And the future is really bright with the tempo of things, the high level of professionalism and discipline in the group. The future is really bright for the group. We are just starting. And within a year, we are now registered, which is an achievement on its own. So we can now proceed to, see if we can get medical and dental council accreditation so that we can issue CME points. The non-clinical professional development group can now function full team, because we were waiting for registration to have our affiliations with people in diaspora to continue. So the future is very bright and the possibilities are opening up more and more. So I just want to seize this opportunity, since we are not having an annual meeting on this day, which is our anniversary, really. June is our anniversary, but just to place on record my gratitude to everyone who has contributed, from the very senior colleagues, the elders of the group, to everybody in the group, both in diaspora and within Nigeria. The confidence you have bestowed on us is encouraging, and it will spur us on to make sure that really the height, the sky will be the limit for this group. So I thank you all very much. And on that note, I welcome you all again to this meeting. So over to you, Dr. Iletu.
Thank you very much, sir. So I will hand over to Dr. Njokanma to kick off the presentation. Thank you.
Good afternoon, everyone. I'm Rukeme Njokanma, a pediatrician at Lifeline Children's Hospital. And with me is Dr. Felix Alakal, a pediatric surgeon. Together, we'll be discussing the topic, the Enigma of a telescoping bowel. I like that Professor Iletu said it's a surgical case, and this is the first surgical case we'll be discussing in this forum. That's really interesting to know that the patients we'll be discussing came in with unusual presentation. I don't know whether it's a surgical problem or not, but she comes into the hospital. She wants to see a pediatrician because of abdominal pain. Crying excessively and pointing at the crying was episodic, lasting about 5 to 10 minutes, and was non-pacifiable. The crying occurred several times during the day and was associated with flexing of her lower limbs. She had an episode of vomiting, but there was no change in the consistency, frequency, or color of her stools. She was taken to a hospital at the onset of her symptoms, where she was managed conservatively with oral antibiotics and analgesics. Child continued to cry excessively and held her abdomen each time she cried. This got her parents very worried and thought to seek a second opinion, hence their presentation at Lifeline Children's Hospital. On examination, this child was initially calm, but later became irritable, crying and holding her abdomen. She wasn't pale, anicteric, well hydrated, and afebrile. Her weight was within normal range, within the normal limits. On abdominal examination, the abdomen was flat, moved with respiration. There was a sausage-shaped mass, concave towards the umbilicus. There was generalized tenderness, no organomegaly, and the bowel sounds were hyperactive. The digital rectal examination was normal. There was no stool in the rectum, and other systemic examinations were normal. The problems in this child were excessive crying, abdominal pain, a sausage-shaped abdominal mass, and we made a clinical impression of intussusception. The abdominal ultrasound scan showed the telescoping part of the small bowel into the proximal large bowel. The segment of the small bowel involved measured 11 centimeters on the right side of the abdomen. There was, however, blood flow within the involved bowel loops on color Doppler imaging. And the conclusion of the scan showed that there was intussusception with mesenteric adenopathy as the lead point. The full blood count and electrolytes were within normal. This child was placed on maintenance fluids, antibiotics, we catheterized her, did vital sign monitoring, and had an exploratory laparotomy. At surgery, we found an ileoceliac intussusception with the apex in the ascending colon and neck in the terminal ileum. There were also multiple enlarged mesenteric lymph nodes, grossly distended small bowel, but both large and small bowel were viable. Her post-op period was uneventful, and vital signs remained normal. The pack cell volume and electrolytes on the second day post-op were normal. She maintained nothing per us for 3 days, commenced graded oral SIPs on the 4th day, and the wound was inspected on the 5th day and was discharged home on the 5th day. The second case is BC, a 3-month-old boy who presented with his parents complaints of constipation of 6 days, vomiting and fever of 2 days duration, and abdominal swelling of a day duration. The child opened his bowel every other day for 4 days, and thereafter did not pass any stool for the subsequent 2 days prior to presentation. Child normally opened his bowel 2 times per day every day. So this was unusual when the child wasn't pooing as he normally did. The child also, 4 days into the onset of the illness, started vomiting, had 2 to 3 episodes per day. They were postprandial, containing recently ingested meals. The vomitus was non-projectile and non-bilous. Body was reported to be warm and transiently relieved by paracetamol. Abdominal swelling was observed a day prior to presentation, and it progressed until they arrived here at Lifeline Children's Hospital. At the onset of symptoms, child was initially observed at home, but on development of vomiting and fever, child was taken to the hospital where child was admitted and managed with intravenous medications for 2 days. Symptoms progressed with obvious abdominal swelling and so was referred to Lifeline Children's Hospital. On examination, this child was acutely ill looking, was pale, warm, mildly dehydrated, not cyanosed, anicteric, and anicteric. The weight was 4.8 kilograms, which was between the 5th and 97th percentile. It was normal. The abdomen was distended, moved with respiration. It was tense. The abdomen was tense and difficult to palpate abdominal organs. There was generalized tenderness, and the bowel sounds were hyperactive. Digital rectal exam showed good perineal hygiene with brownish stool in the rectum. The urogenital system, there was bilateral scrotal swelling that transilluminated and was non-tender. Other systemic investigation were normal. The problems in this child were constipation, vomiting, fever, abdominal swelling, mild dehydration, pallor, bilateral scrotal swelling. The left side worse than the right. And we made a diagnosis of intestinal obstruction. We queried the cause. We also considered the late onset sepsis in this child. We have a plain abdominal radiograph. I'm sorry, we can't see it. The erect view showed that there were multiple air fluid levels and there was paucity of rectal gas, while the supine view showed dilated bowel loops. The abdominopelvic ultrasound scan showed that the large bowels demonstrated significant increase in the structural caliber with remarkable increase in the intraluminal diameter. There was excessive intraluminal debris predominant within the periumbilical, left lumbar, and iliac regions. The peristaltic movement was slow and marginally progressive. The conclusion revealed that the features were in keeping with mechanical obstruction secondary to fecal impaction. The child had mild hypokalemia and anemia of 27%. We passed an NG tube to decompress the abdomen, placed the child on nothing per us, was placed on correction for mild dehydration plus maintenance fluids. We also placed the child on maintenance potassium in infusion, monitored the vital signs, gave antibiotics, and we monitored the urinary output. The second day on admission, the child was still very ill looking, and we have a picture here of the child passing melena, had an episode of melena, dark brown stool. Child had fever as high as 38.4. The NG tube was draining bilious effluents, and the abdominal girth had increased. We optimized the child, corrected the electrolyte derangement, and the fluid status had been optimized, and we planned that this child should have an exploratory laparotomy. In theater, we have a video of this. Unfortunately, we can't see it. In theater, what was found was an ilio-ileal intussusception. And the video would show very clearly how the intussusceptum was milked gently out of the intussusception. And the small bowel, the entire ileum was viable. And that will explain really why this child had melena, because this obstruction occurred higher up in the intestine. The post-op period was also unremarkable. Child did very well. Vital signs were stable, maintained nothing per us for 2 days, opened bowel on the 3rd day, and started oral sips on the 3rd day. Wound was clean on the 5th day and discharged home on the 6th day post-op. The 3rd case is a 2-year-old boy who came in with just abdominal pain of 2 days duration. This pain was intermittent with no known aggravating or relieving factors. There were no changes in the frequency, consistency, and color of his stools. There was no vomiting and no abdominal distension. He was taken to a hospital, from where he was reviewed and asked to do an abdominal ultrasound scan, following which he was referred to us at Lifeline Children's Hospital. He was initially calm, he wasn't pale and icteric, well hydrated, but a few minutes into his review, this child was noted to be holding his abdomen, pulling up his knees up to his chest, and crying intermittently. He had about 3 episodes within a 20-minute period. On examination of his abdomen, it was full, moved with respiration, was soft. There was tenderness. We suspected there was tenderness as the child was crying during the period. There was an ill-defined mass in the periumbilical region, concave towards the umbilicus, and the bowel sounds were hyperactive. Digital rectal exam was normal, and other systemic examination findings were normal. An impression of intussusception was made, and the ultrasound scan done revealed that there was a mass with swelled pattern of alternating hyper/hypoechogenicity, giving a target appearance on the transverse view and a pseudo-kidney shape on the longitudinal view in the right hypochondral region, with associated reduced peristalsis. And the conclusion was in keeping with intussusception. His blood work was within, his electrolytes were normal, but he had slight anemia mild anemia of 28%. Again, he was placed on fluids, nothing but us, antibiotics. We catheterized and monitored his urine output and had exploratory laparotomy. In theater, the findings were an ileocecal intussusception with the apex in the cecum and neck in the terminal ileum, with associated multiple mesenteric lymph nodes. Post-op period was uneventful, and this child was discharged home on the 5th day on post-op. In summary, I've presented 3 cases to you, and one of the cases was a 3-month-old boy, and that's an unusual age for intussusception to present. Normally, the cases will present from the 6 months to their 3rd year. We had a 3-month-old child. The symptoms that were constant here were abdominal pain and irritability. which is normal for every child who would have abdominal pain. Once there's abdominal pain, the children normally would cry excessively. And another thing that was constant in these 3 cases was that there was absence of Coram jelly stools. These 3 cases had multiple hospital visits. And that's why we thought we should share this discussion with you. When our patients, especially infants and younger children less than 3 years, come to us with abdominal pain, we should think intussusception. So a high index of suspicion is paramount when our children come to us, especially the infants and the younger children less than 3. When they come to us with abdominal pain, please let us have a high index of suspicion for intussusception. Thank you very much.
Thank you very much. We'll just go straight to Dr. Alakaloko's presentation.
Good afternoon, my distinguished trainers, teachers, colleagues, ladies and gentlemen. I stand on the existing protocol, and it's a privilege to be in this great company to discuss this enigma of a telescoping bowel. My bit this afternoon is just to share some light on the surgical aspects of this presentation. My objective this afternoon is to determine the epidemiology and the predisposing factors, and as well as discuss the means of diagnosis and treatment options. Permit me to use this above outline for this discussion. Intussusception can be defined as the invagination or telescoping of a part of a bowel into an adjacent part. Usually, it involves the proximal bowel into the distal bowel. It's very important for us to know that it's a common cause of intestinal obstruction in infants. As a matter of fact, it's the most common cause of intestinal obstruction in infants. And as it was first described by a physician in Amsterdam, Paul Babbitt, in 1674. And the first successful reduction of intussusception was carried out by Hutchinson in the United Kingdom in 1871. Why the man, a Danish physician, who incidentally is a pediatrician, named by name Harald Eschprons, did the first enema reduction of this case. So you see why it is important. Just as my colleague, my sister said, Dr. Rukeme said earlier on, that they will present first to the pediatrician, and then subsequently, some of them may end up with the surgeon, and I will explain why. Now, epidemiologically, this incidence is for the developed world. We don't have data for us in this part of the world yet. We hope in the recent time, years to come, we have our own figures, but it occurs in about 2 to 4 patients per 1,000 live births, and it's slightly more common in male than females, ratio of 3 to 1. Well, some people believe that it's commoner in whites than blacks, but until we bring out our own data, then we can effectively have comparative analysis. But what you should know is that the idiopathic type, occurs usually between, that's the peak age of incidence, is between 6 months and 10 months. So a typical patient with intussusception will be between 6 months and 10 months, who is otherwise well fed, most likely a male, and then coming down with this condition. Just about 25%, 10 to 25% occurs after 2 years. So the age of incidence is usually between 2 months and 2 years, or stretching it to 3 months to 3 years. Now, there are seasonal variations, and this has been well documented because of pockets of this condition being picked during time of rainy season in this part of the world, and during winter among the Caucasians. And this has also been associated with some strains of viruses which were implicated and was actually found in the nationwide survey study that was done in Copenhagen. Now, the pathology of this condition, it has this clinical entity has parts. The proximal part, which usually is the terminal ileum, which is telescoping into the receiving part, is called the septum, while the distal part, which is the receiving end, which usually involves the cecum and the ascending colon, is, or down to the transverse colon, as the case may be, is known as the intersocipens. And in between them is what we call the neck. Now, sometimes we have identifiable lead points as a cause. This occurs in just about between 2 to 8% of cases. And I will talk about the pathologic lead points involved. But there is usually a pointer that leads it, whether it's in the idiopathic type or in the pathologic type. And what has been noticed is that the hypertrophy of the lymphoid tissue is what initiates the process of the telescoping, coupled with the hyperperistalsis of the bowel. Whereas in about 2 to 8% of patients that have a distinct anatomic lead point, it's due to an anatomic entity, which I'll mention. Now, I just put this picture on. It's one of the recent pictures that I operated in our hospital, which has this telescoping bowel. So if you can see the distal part, this part is the head, this is the leg, and this part is the terminal ileum, and this is the cecum with the ascending colon, receiving it into, as it telescopes into it. This I normally use for my medical students to identify the parts of the interoception, and this will be labeled A, as that's the interoception. This is the neck, and this, the telescoping part, is the interoceptum. So what happens? What's the pathophysiology or pathogenesis of this condition? Now, what we know is that there are predisposing factors to patients developing hyperperistalsis, hypertrophy of the Peyer's patches, and then leads to, the progressive telescoping. While this progressive telescoping goes on, in many instances, there is spontaneous resolution that we never get to know. But in those that this resolution does not occur, the telescoping progresses, carrying along with it, which is mesentery, and this leads to a venous compression from this invagination of the bowel. And this venous compression with contraction of this telescoping bowel leads to the venous stasis, and this is what causes the sausage-shaped mass that we normally palpate, which usually is concave to the umbilicus. Now, the venous stasis, if it's unabated, will lead to edema. With worsening edema, there is increase in the pressure, both in the venular end, that will now lead to lymphatic obstruction, and ultimately that will decrease arterial blood flow. With the decreased arterial blood flow, there will be ultimately bowel ischemia. And this is what leads to the entrapment of the mucoid clots, which has been denuded from the mucosa, that mix with the mucus within the bowel, and that patient passes out, that we call the Coran jelly stool, which is one of the indicators that once we see, we suspect that the patient may be having interoception. Now, I put this up because this is just showing a patient that has the sausage-shaped mass that was palpated, and as soon as the abdomen was opened into, this is the mass that is in the center. The mass shows out. Now, interoception can be classified into, based on the etiology or etiopathogenesis, just as recently just discussed. It can be primary or idiopathic, which accounts for over 90% of cases. And sometimes it can also be secondary. That means there is a pathologic lead point leading to this condition. Now, for those that are primary, what we know is that there are predisposing factors to this idiopathic occurrence. And those are things that lead to hyperplasia or hypertrophy of the Peyer's patch, such as viral infection. Whereas for those that are secondary, usually there is a pathologic entity, as I mentioned earlier on, and this tends to occur more in patients who are older than this age bracket of 2 months to 2 years, or 3 months to 3 years, as the case may be. And usually, this one will require surgical treatment. So let's quickly talk about the primary idiopathic interoception. For them, the peak age of incidence is between 6 and 10 months. As I mentioned earlier on, 65% of them will have occurred before 1 year, and thus less than 25% will occur after 2 years. Now, this idiopathic interception usually occur during epidemics of viral enteritis, and it's important to note that the viruses that have been implicated are adenovirus, rotavirus, reovirus, even ecovirus. Now, rotavirus is important, even though we don't use the rotashield antivirus, I mean immunization, but it was involved when rotashield was rolled out, that there was 22-fold increase in the incidence of intussusception in the area where it was used, and that particular strain, strain was removed from circulation and was made more. It was made more accessible. The virus was killed. The live attenuation was made to be less virulent, and then the rotavirus that we have that we circulate and we give to our children these days does not cause intussusception. It's just for us to know that this can happen. Also, you should know that whenever we have intussusception in that age bracket, we can assume, we can take it for granted that they are most likely from idiopathic source. And so they may be amenable to treatment non-surgically, and in some other instances will require surgical intervention. Now, I say that with strict caution. The non-surgical intervention is reserved only for patients that present early. And we know in our environment, patients don't present early for obvious reasons: primary delay, secondary delay, and tertiary delays. Now, 2 to 8% of patients have pathologic or anatomic lead points, and it's important for us to know what are these pathologic lead points. The most common in the literature and even our environment is Merkel's diverticulum. When patients have Merkel's diverticulum, the first time they are presenting may be as intussusception, and it's when we operate we now find out that there was a Merkel's diverticulum within the intussuscipient. Also, patients that have mesenteric cysts, duplication cysts of the bowel, polyps, ectopic pancreas or gastric mucosa, foreign bodies. Also, patients presenting with appendix can be a secondary source or a lead point. And I've personally seen a couple of patients presenting with intussusception that ended up to be carcinoid tumors, and a few cases were actually non-Hodgkin's lymphoma that serve as a lead point. So that is intussusception does not mean that they cannot have all other causes, which are the lead points as mentioned. Another way you can classify intussusception is based on the direction of the telescoping. Now, majority of time, it telescopes from the proximal to the distal bowel, and this is the antegrade movement, and that we call antegrade intussusception. Whereas in some instances, you can also have retrograde intussusception, which have been described in literature. It's the setting of a patient who has had surgery previously, a gastrojejunostomy, when the gastric part of the jejunostomy of this anastomosis is wide or too wide, not made to be adequate size or small size, then it can easily, telescopes retrogradely into the stomach. So that will not usually be seen except a patient who has visited surgeon previously. But majority of all the patients presenting with intussusception, we have antegrade intussusception. So how else can we classify intussusception? These are the antegrade intussusception. You can classify based on the anatomic parts of the bowel that is involved. And about over 80%, about 80 to 90% of patients will present with an ileocolic intussusception. Why? Because usually when these patients have this viral infection, you know that children cannot swallow phlegm, and the phlegm usually the upper respiratory tract area is loaded with a lot of viruses in patients that have a preceding history of upper respiratory infection. They swallow all their phlegm, and this may escape the gastric acidity and get into the small bowel, and then it gets with the Peyer's patch in the terminal ileum. There is increased hyperperistalsis, and then there is hypertrophy of the Peyer's patch, and then it starts around that area. And that's the reason why most of the patients come down with an ileocolic intussusception. Other forms of intussusception, ileoilia, very, very rare. I think that was what Dr. Njokanma presented, that the patient presented with an ileoilia is possible. Also, cyclocolic intussusception, colocolic, and sometimes jejunal. And sometimes you can actually have combination, which has been documented. Recently, we saw we had 2 case reports of 2 patients that had combined or multiple forms of intussusception, which was detected intraoperatively. Clinical history of this patient. Most of the time, it's an SY, well-nourished, chubby, 9-month-old infant. Between 6 months and 10 months is the peak period we said, and most of them, 90% are idiopathic. So it's usually most of the time a well-nourished, well-fed infant, usually a male, with paroxysms of sudden onset of colic abdominal pain, which may be described as discomfort, may be described as raising up of limb, drawing limbs towards the body. Sudden resolution also happens in between those bouts. When a patient suddenly becomes uncomfortable and cries with the high pitch, and then it resolves, and sometimes they can even sleep off following that period, those are the early signs, and it's found in 100% of patients. It's only that many people don't see pediatricians. They go elsewhere, and those places, they don't have people that have the high index of suspicion. Vomiting is seen about 80% of patients with intussusception, and when a child starts to vomit, especially when the vomitus is now bilous, is cause for concern, and we must investigate appropriately. And lastly, the patient will present with bloody mucoid stools. In the past, we say they usually have a red currant jelly stool. This is fine in about 95% of cases. And the red currant jelly stool, as I explained earlier on, is as a result of the mucus mixed with the entrapped blood clots from the ischemia ongoing within the bowel wall that is strained, that has been denuded of blood supply and has broken the ends of the vessels, and it bleeds into the mucus and it mixes with it. But sometimes this red currant jelly can be found to be like a black currant, and that may explain why what Dr. Njokanma mentioned earlier on about the patient that presented with what looks like a melena. So a child, an infant bleeding may not be dysentery, may not be any other thing, may most likely not be a lower GI bleeding, but usually may be intussusception. And it's worthy of note that red currant jelly stool or black currant jelly stool, as the case may be, is a late sign. It's not one of the early signs. And when the patient is presenting with that, it shows that we need to work fast. We need to run and be on top of the issue, in the case. Now, these patients usually we are well preserved. Sometimes they are dehydrated depending on the duration of the symptoms. And sometimes they can present toxic, like the second presentation that was mentioned just now, can present toxic with, they can have fever because the pathophysiology is ongoing, and they can actually come down with, severe dehydration. In some instances, you have seen patients that come down with septic shock, and these are all late presentation. Otherwise, most of the patients should come with discomfort and should be picked and should be intervened. Intervention should be carried out within hours. The earliest intervention I've ever been involved with was within 6 hours of presentation, and that was a colleague's child who just noticed, who apparently did his postings well when he was passing through surgery or pediatric surgery, and what he was seeing in his child was a cause for worry. And immediately he put a phone call to me, and I told him to come immediately. And we did the ultrasound scan, and that was it. We had non-surgical intervention, which I will discuss soon now. Also, there may be sausage-shaped mass in the upper abdomen. There is what we call the sign of Dunn's, which is a relative emptiness in the right iliac fossa with a palpable sausage-shaped mass concave onto the umbilicus, and then the patient is having pain, intermittent colicky pain. Once we have that, then you should suspect that this patient may have intussusception. And rarely, which most of the literatures will not record, but which we find in our environment is when patient has prolapsing mass through the anus. Not all prolapsing masses are rectal prolapse. That should be a take-home point for today's discussion. And if a child is unwell, has abdominal distension, is vomiting, and is having intermittent colics, and also has a mass protruding in the anus, then we must investigate for intussusception. And I put a picture up of one of my patients who has a prolapsing mass. You all know that this is a grave sign in intussusception. It should never happen in developed countries, in sane climes. We should never have our children going through this ordeal when the intussusception, the telescoping that has begun from the terminal ileum is allowed to go through the ascending colon, to the transverse colon, to the sigmoid colon, and then to the rectum. and then ultimately to the anus until we now see it glaring at us. Why I said an omnium sign? Because from my own experience, out of every 10 patients that come down with rectal prolapse, only 1 will survive. 1 to 2 will survive. 8 of them may not make it. And that shows that it's very serious. It's not something that we see and we joke around with. This patient will definitely be in shock, severe dehydration, may even be a progressed septic shock, because usually we have ischemia that may have perforated, and then usually even those that survive will have extensive bowel resection that we end up with short bowel in fissure or some forms of metabolic derangement. So how do we make a diagnosis? I stated there, diagnosis of intussusception is mainly clinical. Investigations should be an adjunct. And this should be one of the take-home points from this discussion, that once we see this triad, however, we should take caution. This triad of colic abdominal pain, mucous bloody stool, and sausage-shaped mass in the abdomen is only found in 35% of patients. So it's not all the time, but we will find out 100% of times, 100% of patients we have intermittent colicky abdominal pain. 80% of patients we have vomiting. Another about 80% of patients may also have mucoid bloody stool, which can be a red currant jelly stool or a black currant jelly stool, as the case may be. So with that, we are armed with enough evidence to suspect that this patient has intussusception, and also go ahead to investigate just to confirm diagnosis. And the commonest investigation we do is not X-ray, is not barium, but it's an ultrasound scan. But in some instances, because you are suspecting intestinal obstruction, because there is abdominal distension, there is palpable mass, there is vomiting, you may want to do an abdominal X-ray. It will not show you much. It just show feature of intestinal obstruction, which will stack up points appearances, as the case may be, or a soft tissue mass. It will not really help, except the eyes of that person is well trained to pick very simple, minute details. And sometimes some people who have done a barium enema which show the coil spring appearance. These are all highfalutin. This is the main deal. In the hand of a good sonographer, ultrasonography is the mainstay. It has about 100% sensitivity and specificity. So we see this wildwood appearance, which is known as the target sign, which once it's seen, we know that, or our eye sign, we know that this patient has, a telescoping bowel that is, causing the obstruction. Also, the pseudo-kidney appearance, when the ultrasound probe is placed longitudinally in the middle part of the upper abdomen, we see what looks like a kidney in the position that is not the kidney's position. The kidney should be in the flank. That's what is known as the pseudo-kidney appearance. With these two, sensitivity is as high as 100%. In very sophisticated settings and in developed clients, they may also want to do a laparoscopy before they do a laparotomy. And that's because sometimes when they want to go and operate, during anesthesia, during induction of anesthesia, there may actually be spontaneous resolution of the intussusception. So they don't want to just give elaborate scar. So they may just put a camera through the umbilical port and then just check and examine, and you'll be able to see, which is, it's visual, and you can see. Now, the free blood count may be deranged, it may not be, it may be elevated white blood cell count, and it may be normal. The electrolyte urea and creatinine usually will be deranged if the patient is presenting late. But if it's an earlier presentation, of course, they will still be normal. Then it's important for us to do blood grouping and cross matching, because this patient going for surgery may actually require transfusion. Now, before we go to the management, what are the other things? If it is not intussusception, what test can it be? The other causes of intestinal obstruction in infants are malrotation of the gut, which we present with bilious vomiting, and there will be no mass palpable. Okay, and usually when we auscultate, the patient will have high-pitched, hyperactive bowel sounds, and the patient will have been having history of recurrent vomiting in the past. Duplication cyst, that may not show anything. When we investigate the patient, we just see like a cystic collection within the abdomen, and an ultrasound scan can give that out to show the collection, whichever part of the bowel has that. obstructed inguinal hernia. That's why it's important to examine our patients. Some patients actually had incarcerated or obstructed hernia that is presenting even though they are infants. It can be an umbilical hernia, it can be an inguinal hernia. And people have missed that diagnosis and treated patients for something else, whereas the problem was in the groin. So it's important for us to examine our patients well. Abdominal masses from tumors can also present as intestinal obstruction, okay? Hodgkin's lymphomas and other abdominal masses. Sometimes gastroenteritis mimic this condition, and it's important for us to distinguish and not over-rely on treating gastroenteritis, whereas this patient actually has a mass. So it's important that any child in that age bracket that has what we think is gastroenteritis should benefit from an urgent abdominal ultrasound scan to exclude intussusception. Then you can continue management for gastroenteritis. And also, I mentioned rectal prolapse. Of course, rectal prolapse can occur in that age bracket, but in the case of rectal prolapse, usually they will not have intermittent colic abdominal pain. They will not have vomiting that may be villous or not even non-villous. And the rectal prolapse, usually we just have a mass that protrudes and disappears. So they may not even see when it comes to the room, to me, the surgeon or the doctor, as the case may be, you will not see any mass, and that mass resolves spontaneously, except it's a procidential, if it's a third degree, and then the mass will persist and will be there. And of course, when you insinuate your finger, you can easily return it back. And there is usually a wedge in between the end of the mucosa and the end of the rectal prolapse that usually will not take more than a little finger. So those are the differential diagnosis. Treatment. The treatment of intussusception begins with the pediatrician. A pediatrician must have seen this patient because they present to them first. And he must have noticed that this patient has features of hypovolemic shock or hypovolemia or severe dehydration. And so the patient is placed on NIPA oris, intravenous fluid is administered, as the case may be. Some people prefer Ringer's lactate, other people prefer normal saline. And you pass a nasogastric tube, appropriate size, not too small a size that cannot do anything, to decompress the stomach, okay? And that will relieve the pains and the current episode of paroxysms. Also, a rectal catheter will be passed to monitor adequacy of tissue perfusion, to monitor how the patient is doing well, because some patients come down with already brewing AKI or full-blown AKI, and they need to be resuscitated appropriately. Antibiotics must be started because it's an intestinal obstruction and the risk of transmigration of bacteria is high. So antibiotics, a broad spectrum cephalosporin should be commenced. And what are the definitive treatments for intussusception? I said earlier on that they can be non-operative or operative. Now the world is tilting towards non-operative management and shying away from the operative management because of the morbidities, scars involved, and also because the patients may also have other comorbidities. Now, for non-operative management of intussusception, as far back as 1872, a pediatrician named Arad Eshpons first used Enigma. What he tried to do was just to use Enigma saponis to outline what is causing this in these patients. And incidentally or mistakenly, it reduced that swelling, that mass in that patient. And that informs the same principle that we use now for non-operative management of intussusception. Now, what do? It's either we use hydrostatic reduction using saline or pneumatic reduction. In my center, what we use is hydrostatic reduction. I know that pneumatic reduction is what is being used in Ghana. That involves the use of gas, either CO2 or oxygen, or just ordinary air from a pump, which is graded at a pressure of between 100 and 120 millimeter of mercury, and they push it and they observe under fluoroscopic guide to see the resolution of the mass. That is what is done. But what we do is hydrostatic reduction, where we use saline. This usually is done as a double setup. Whenever you are going to do hydrostatic reduction, there must be theater sets by the side. because of the possibility of perforation, which can lead to peritonitis and can lead to septic shock, which you don't want to happen. So the minute you see fissures of perforation, which in our setting we use hydrostatic reduction, which is water. We use normal saline, we hang it at a height. We use what we call it the rule of 3, a height of 3 feet from the patient, and then we don't do more than 3 attempts, and each of the attempts does not last more than 3 minutes. This is just a guide for us to forestall the incidence of inadvertent perforation during this procedure. And then we use it under ultrasound guide. So we don't have to use fluoroscopy, which is smaller, that's more radiation to the patient and also more expensive. Ultrasound guide, we just put the ultrasound and we look at the fluid as it passes through the terminal ileum, retrogressing, flowing back from the cecum to the terminal ileum. You see the mass unraveling, the target sign or the our eye sign that we see on ultrasound scan, we see it dissolving, and we see the mass unfolding as we are putting the fluid into it. But there's a caveat, and the caveat is that for patients that we will do non-operative hydrostatic reduction for, one, the duration of symptoms must be less than 72 hours. They must not have fever. There must be no evidence of toxemia or shock or peritonitis in the patient, and the patient must be making adequate urine, and there must be double setup. These are the 5 things that we do, and this has been published in a work done in our institution by Olumide et al. I was part of that publication, where we had an initial experience of using this hydrostatic reduction for our interception using that guide, and there was no mortality. Now, the success rate of this hydrostatic reduction in our institution was 42.3%. That is at variance with other studies from other high-income countries of the world, where they had as high as 70 to 80% success rate. In fact, I was privileged to be in a place in the United Kingdom, and their success rate was as high as 90% in Great Ormond Street Hospital. So that is to show that we can move towards that, we can achieve it. But one of our problems, our challenge is our patient present late. So there is a poor air-seeking behavior of our patients. Then when they present at other places where they don't pick it. So there's primary delay, there's secondary delay. And when they come also, they come so late, and it's too late for you to attempt hydrostatic reduction. Hence, they are condemned to have surgery, and they will have a scar which they will carry for life. Contraindications, I've mentioned it. If the patient has gangrene as well, you should not do hydrostatic reduction. Now, patient can also have this sorted out laparoscopically, and we have done quite a number as well. Using minimal access, you don't have to have such a big scar over the abdomen like this. You can use pins, and then we just mobilize. But we select our patients, of course. Anyone that has a mass already on the left side of the abdomen, we will not take for laparoscopy. So on a typical patient that is going for operative, you'll be under general anesthesia. You will have laparotomy done. Usually, we have a right transverse incision, as depicted in the picture on our screen, and the mass is milked out, which is called the Bishop Cope's maneuver, where we don't pull it, otherwise the bowel will tear. We milk it out from the end of the intussusceptum to the end of the susception, and then it comes out gently. And then we assess for viability of the bowel, because sometimes what are telescoped may be dusky and it may not be viable. So if it's not viable, then that's an indication for resection and anastomosis. So we do a right hemicolectomy or a colectomy, as the case may be, or sometimes an ileal resection and anastomosis. So this picture just depicts what takes place. If, for instance, you are doing a laparoscopy, this is the approach. We don't make out like the open. In the open, we make from the insusception end, and then we just hold it here. We don't pull it out. We only make for this is the only one that is making the movement. This one does not make any movement, does not pull. All right. Whereas in laparoscopy, this is a maneuver that we use to separate it. Now, sometimes the bowel is non-viable. Not even sometimes, many times. We had a series 4 years ago, and we found out that over 60% of our patients had gangrenous bowel, and that's no thanks to late presentation. And once we see that, I said so, it's an indication for resection anastomosis. That increases the morbidity and length of hospital stay for the patient, unlike the one that Dr. Njokanma presented, that within 4 days, patient is already aging to go home, and by the 5th day, they were discharged. What are the complications of this condition? There can be recurrence, and usually recurrence will occur within 3 days to 6 months. The recurrence in insusception is common now with patients that had non-operative reduction. Non-operative reduction using hydrostatic reduction or the pneumostatic reduction with ultrasound guide for hydrostatic or with fluoroscopy guide for the pneumostatic reduction. And the patient can present with symptoms again. And if they present with symptoms, it's not a contraindication to go again and do non-operative, especially if they present early. But if they present late or have symptoms, features that suggest that there is already, sepsis going on, or there is electrolyte derangement, patient is unstable, then it will be good for go ahead and do operative reduction. More so, importantly, if by the time you are operating the patient is already tilting away from the age bracket, 2 months to 2 years or 3 months to 3 years, such patients usually may have an anatomically point that will require surgical resection. So that may be a reason for operating. Also, some patients will come down with surgical site infection, especially if the patient had perforated viscous, had already gangrenous bowel, and you have to reset and anastomose the patient. Usually, mortality in insusception is due to inadequate resuscitation, and that's why we cannot overemphasize the need for resuscitation, which starts from when the patient is seen till when the patient is operated and after operation. And of course, other reason for mortality in the environment is late presentation. And one thing I am an advocate for is whatever we can do. I'm looking for that thing that can make our patient present earlier, and then we have non-operative reduction more commonly done with good outcome, so that we can begin to compete with the international community. Of course, surgical complications can also be a complication. Surgical complications like injury to about nearby structure, anesthetic-related complication, patient can come down with atelectasis post-surgery. Of course, post-operatively, patient must be followed up. Okay.
Okay. I guess we can start the question and answer session whilst we wait for Dr. Alakal to come back on.
Okay, sir. Good evening, distinguished elders, senior colleagues, and my friends. It's really lovely seeing you all this evening. And we've definitely had a very interesting session, despite all the technological hitches. I'm sure we have all learned a lot about the varying presentation. You can choose to speak or raise your hands, then you can be recognized. Any question or contribution, experience sharing? I have a question myself. I don't know if the surgeon can hear us. Is he with us, Dr. Letu? Hello, can you hear me?
Yes, we can hear you.
Okay, I was asking if the surgeon is with us. I have a question for him. Maybe it can help to jumpstart our discussions.
No, he's not back yet. But I guess you can ask your question. Maybe Dr. Njokanma can, or any other person on the group can throw more light to it.
Yeah, actually, a comment that he made that a rectal prolapse, or rather what we suspect is a rectal prolapse, and every mama and kaka like to push it in routinely as if it's just a normal rectal prolapse, without thinking of the possibility that it can be a more serious surgical problem, caught my attention. And I wanted him to be able to at least give us some differentiation, because sometimes children just come with rectal prolapse, and even as clinicians, we just push it back in, So apart from history of excessive crying periodically, is there any other way we can differentiate a prolapse from a regular rectal prolapse from that of an intussusception? That's my question. And then what turns a red currant to a black currant jelly? Second question. Thank you. Any other questions from the floor?
Well, Dr. Njokanma, can you attempt to answer the question? Dr. Wo, are you online?
Yes, we are. Dr. Njokanma is here. Yes, ma'am.
Okay, can you attempt to answer the question?
Yes, I would attempt to answer the second question to be safe and leave the first one for the surgeon. Okay, so like this patient, this is the second case that was presented. And just like he said, it was a toxic this child was toxic at this point. We can see the dark currant jelly stool in this child as against the red currant jelly stool we will see in 95% of cases. So this dark or melina stool is because the obstruction occurred higher up in the gut. This child had one of the unusual presentations. It was an ilio-ileal intussusception. And the higher the obstruction occurs, the blood, as the blood passes down through the intestine and the processes of digestion and breakdown occur, the red stool changes color to a dark stool. If the obstruction or intussusception occurs lower down, that is now ileocecal, which occurs in more cases from the small intestine to the large intestine, you would see a red currant jelly stool. So depending on how the level of intussusception, if it goes higher up, you would find a dark stool. If the intussusception is lower down in the large intestine, you would most likely find a red currant jelly stool. And the ileocecal intussusception is more common than any other, as was presented by Dr. Alakal.
Thank you so much, Dr. Njokanma. That has certainly made it clearer in my mind. I believe in people's minds too. Thank you so much.
I think Dr. Alakal is online. So
Apologies, sir. From the
round up.
No thanks to the system, just went off board. Can we see my slides? Hello, sir.
No, not yet. Not yet.
Can I just show you a video of what Dr. Alakal was talking about the gentle milking of the intussusceptum from the intussusception.
Okay. Whichever comes faster. Can you see the slides now?
Yes, please. Yes, we can. Go ahead.
All right, sir. Sorry for the break in transmission. I was discussing the incidence of post-operative intussusception and how it can occur. The cause is unclear. Okay, but what has been propounded is as a result of prolonged fasting in patients who have undergone surgery with hyperperistalsis that now leads to it. This one is very difficult to diagnose because you will never expect that it will happen. And so that's why we need to have a high index of suspicion. The last case I had was a patient who had surgery for pyeloplasty for pituitary junction obstruction, which has no bearing with the abdomen, it's just in the flank to the kidney. And then patient came down with intussusception. Of course, the patient has to have another scar, for that purpose. Most of these patients, these incidents occur within 1 month. Symptoms can start as early as 10 days. This is for surgeons to be aware so that we are not fooled and think all is well. So I want to conclude with this slide that of utmost importance is that we must look out for incidence of recurrence, which is high in non-operative. As far as we wish to tilt our management plan towards non-operative, which is the desired, we should also remember that the incidence of recurrence is higher in them, and so we must watch out for them. Long-term complications in patients with intussusception in our environment has been found out to be things like megaloblastic anemia. And this occurs because most of them, I say about 60% of patients will require resection. And if you resect the terminal ileum in the patient, they definitely will have some form of megaloblastic anemia because the intrinsic factor is found in the terminal ileum, which is taken out. So such patients are meant to be monitored over the years and given cyanocobalamin shots yearly or tablets containing that, so that they don't come down with that. Of course, sometimes we see patients come down with short bowel syndrome, especially those that survive the rectal prolapse intussusception, prolapsing intussusception, where you have to exercise an extensive amount of bowel from the small bowel down to the sigmoid colon in some instances. And immediately after surgery, they will come down with a lot of electrolyte remain because they'll be pulling watery stool for upward of 3 months. So that period is usually very, 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 very difficult to manage. And of course, what we must take home is that if there is blood mixed with stool in an infant, it is not always dysentery. We must always think of intussusception. And finally, we must, as advocates and as champions of the children's sake, make sure that we mitigate against primary, secondary, and tertiary delays in diagnosing and in institution care, and also definitive care for the patients that may have intussusception. Thank you very much for your attention.
Thank you very much. Maria.
Yes, thank you so much to a distinguished and dynamic surgeon. You definitely have done justice to the subject matter. And those of us that are non-surgeons, we can probably begin to talk like surgeons now when it comes to intussusception, right? Okay, the floor is open. If there are questions or comments or contributions, I can see a question in the chat box. It's from Mac F. It says, thank you for the excellent presentation. After the initial resuscitation with normal saline or Ringer's lactate, which type of fluid do surgeons prefer for subsequent administration and why?
Okay. Thank you very much, Dr. Mark. Can I go ahead and answer the question?
Yes, sir.
Okay, thank you very much, Dr. Mark, for that very important question. For us, usually we like to maintain the patient on Ringer's lactate cocktail. We add glucose to the Ringer's lactate so that the patient can have something very close to physiological fluid, both post-resuscitation, into surgery, and after surgery. I hope that has answered your question.
Yes, I believe that should make it much clearer. Any other comments or question, contribution, experience sharing? Okay, I think.
Hello.
Yes, sir.
Hello.
Yes, sir. We can hear you. Please go ahead, sir.
So many years ago,
Yes, sir.
at about 2 o'clock in the morning, I had a child brought here with not abdominal pain, with fever and so on. He was brought in from another hospital because they wanted to operate the child for intussusception. What happened was the child was February, and you know when they die, sometimes they have deep, fitful sleep. They sleep a bit, they wake, and then they cry. And of course, what that child had was malaria. So, and fortunately, as I normally do, I gave that child the usual anti-malaria. I usually dose them myself before they go and ask them to see me in the morning. And lo and behold, the child was better. That child would have been opened up because it was when they said they wanted to operate that the mother took the child into a hospital. And I hate to say that the owner of the hospital was a consultant pediatrician. So in mentioning the differential diagnosis, and I heard what Dr. Alakal, the surgeon, said, It did them very well. But and lastly, he said we should train and educate our subordinates. And I think this is very important. Thank you very much.
Thank you so much, Baba. It's always a pleasure to learn from you. Deep wealth of experience. Thank you, sir. So they say all that glisters is not gold. So sometimes different shots can be a little longer than what we seem to see. Are there any more questions?
Some hands are up.
Yes, sir.
Maria, some hands are up.
Yes, sir.
I can see Professor Grange.
Professor Grange, yes.
Professor Grange.
Go ahead, ma.
Yes, thank you. Thank you very much for your wonderful classical presentations. I've often wondered why intussusception is commoner among well-nourished children. Does anybody have an answer to this? Because we have a lot of malnourished children who don't present with intussusception. Why are they protected against intussusception?
Thank you, ma'am. The
So
surgeon.
there's also Dr. Ajayi Obe. Maybe we can take all the questions together, Maria. There's also Dr. Ajayi Obe's hand is up, and Dr. Anyele's hand is up as well. If they can unmute and ask their question now, so we can take the answers together.
Yes, I can't do that. It's only you as a co-host that you're able to see it. So please go ahead.
You click on participants, Maria, go to see everybody.
If you click on participants, you will see them there.
Just click on participants.
Yeah.
Yeah. All right, so please go ahead.
Can Dr. Ajayi Obe go on, please?
Dr. Ajayi?
She just left, so I guess Dr. Anyele can.
Dr. Anyele then, please. Dr. Anyele.
Good evening, everyone.
Okay.
Good evening.
So please, my question is for a child presenting with colicky abdominal pain of 2 days duration associated with bloody diarrhea. Is it advisable for the child to do abdominopelvic scan just to rule out intussusception? Thank you.
Thank you, I don't see any more hands up, so maybe the question can be answered now.
Thank you very much for the questions and comments. They are well appreciated. I'll start with the last question. The patient with colicky abdominal pain of 2 days duration and also having bloody diarrhea is not out of place to ask for abdominal ultrasound scan. In fact, if you follow the presentation very closely, I said that that must be done as soon as possible to exclude if you are thinking you are managing gastroenteritis and you have not excluded intussusception, then you have not done all due diligence. So it's important to do that to rule it out, because the sensitivity is quite high in a good hand. That sensitivity of detecting intussusception with ultrasound scan. And for Prof. Ma, thank you, Ma, for the question. As a matter of fact, we used to, when we were in school, we were taught that intussusception is associated with chubby patients, fat patients, and that the malnourished patients don't have intussusception. But now there is a work going on right now, which is not in support of that, and that's because we are now seeing many of our patients who have who are actually malnourished also presenting with intussusception. As a matter of fact, there was a work we did in 2016 that look at the epidemiological profile of patients with intussusception, and we found out that up to 50% of them had some form of undernutrition, not well fed, as it were, chubbiness, as that the nutrition used to say. What is causing this, we don't know, but what we know is that whether his child is well fed or not well fed, that period of peak of incidence between 6 months and 10 months coincide with the age of time of weaning. And when they are weaning them, it also coincide with the time when they are in the beginning of the oral phase of their development, when almost everything they touch goes to the mouth. And so if the parents or the surrounding is not clean for the patient end up taking, things into the mouth. The risk of having viral infection is higher in them, and then usually they will have a preceding history of upper respiratory tract infection or a gastroenteritis, like a viral infection preceding it. And we know that those who are malnourished also are predisposed to having viral infection as well as the well-nourished.
Thank you very much.
Thank you, Ma. Thank you, surgeon, for the day. Any more questions, contributions? Indeed, it used to be the that it was only in well-nourished children, but as you rightly said, recent, we actually do see cases in children that are not so well-nourished. And it might be related to all the explanations you have given. I think we've had a very rich discussion. If we have any more comments or questions, please feel free to raise your hand. If not, I'll hand us over back to Dr. Eletu and our chairman to conclude the meeting.
Thank you very much, Maria. I want to say a big thank you to Dr. Alakal, Dr. Njokanma, Dr. Wo for the presentation. Let me also apologize profusely for the disruptions we had due to technical issues. It rained heavily in Lagos today, and it's still raining. So I guess that's what has affected the networks across various platforms in Lagos. So please, it's not in our character to have presentations that are disjointed, but today just happens to be one of those days. So I would like to call on Dr. Mbalaji Lawal to say final words before we round up.
Okay, thank you very much, Sanjay. There's nothing more to add, just to thank everyone for their patience, for staying through with us, and to apologize again for the technical hitches. It's been an interesting session all the same. The only thing I can add is, in line with what Dr. Ajeni Fuja was mentioning, that we should encourage the younger ones working with us to examine these patients. I see that some people don't even like to examine abdomen again. They don't. A child that is having any GI symptoms should be examined properly to begin with. And every good clinician should be able to come to a reasonable idea whether this abdomen, I need to worry about it or not. Just like that doctor that the earliest case that they operated, who knew her clinical signs and was able to come to a reasonable conclusion that saved the life having a very early operation. So that's just what I needed to add, that yes, it's good to do ultrasound scan, to do all the various investigations in addition, but they should not replace thorough clinical examination and assessment of the patient. That's all I need to add. So thank you very much, Dr. Eletu.
Thank you very much, sir. And thank you to everybody who has participated in this presentation today. Our next meeting will be in July, precisely July the 28th. And we're expecting a presentation from one of our doctors in the diaspora. So please, we should all look forward to that, and we'll soon start sharing the details of the presentation. Thank you very much, and God bless you all. Bye for now.
Thank you, sir.
Bye-bye.
Bye.
Bye, sir. Thank you, sir.
Bye.
Bye. Thank you. Bye-bye.